So with that, I will close the introduction, and I'm looking very much forward to hearing from Dr. Lawrence Meyer about genomics in the VA system.
So thank you very much. I want to start by just talking about what the VA is, because I think there's not confusion, but most people don't really realize its scope. And then I'll show some actual data that we pulled quite a few years ago, but it just got published last year, and the way that there is disparity in the VA, and then the way that we're addressing that. And a little bit on data. We weren't supposed to talk about research, but I can't not talk about research. And then what we're doing that I think will actually at least start on addressing some of the disparities. So clearly the barriers can exist at every level, and that includes within the VA. We are a system of over 180 hospitals. I think there's formally 172 medical centers, but several of those have more than one hospital. We have over 1,100 outpatient clinics, and then also community vet community centers that don't give medical care but can give social outreach. And so we have altogether over 1,300 points of care split across the nation. We're also both a payer and a provider of care. So we're a lot different than most of the systems. There are, in round numbers, 21 million living veterans right now. There are about 11 million of those that are enrolled in the VHA to receive health care. And we've seen over 9 million of them, and we think that about 8 million are going to come in through our doors this year. So that's and the daily volume is just huge. So many of these people also have some private insurance. And so we are a biller as well. And that's changed. When I first came into the VA over 35 years ago, it was great. We didn't have to mess with documentation, filling out encounters. The only thing you cared about was the note that you'd use for yourself next time or that your colleagues would use. But now we do have to complete encounters every time. But depending on your priority status, that is, if you were a POW or you're 100% disabled, everything is covered. And then it's graded, and one of the factors is your ability to pay. So we do provide care pretty much across the board. The data that I show is just off the VA website, but this down here in very small print, the dark blue says that it's 51% or higher prevalence among veterans who are receiving care in the VA, and so that's income less than $35,000, and so that gives you the sort of the economic, some feel for the socioeconomic background of the veterans we serve. Now some are college educated. They come from all backgrounds. It's highly diverse, but we really have a population that is different. And once again, we provide care regardless of ability to pay. So that's not the first thing we check when people come through the door. So that's quite different. You can see Hawaii is out there. We actually have a hospital in Manila, and we have quite a few outpatient clinics scattered across the Pacific Islands. So it's, we span more, we cross the date line even. It's a little crazy when you're trying to schedule telehealth appointments, I can tell you. Here's the racial background. Now, this wasn't done under the 1970 or 1990 census. This is the box that people check, and it's not always populated, but it shows that we're about 75% white, non-Hispanic, and over 10% black. Now, what's hiding in these is that there's big differences in the trends by time. We had a big bulge in the snake, if you will, after World War II, and then after Korea, after Vietnam. And what you see is that the Vietnam and then pre the 9/11 veterans were more black, and now we're swinging to more Hispanic. And so you can see different, and those that are over 65 tend to be more white. So this is changing as we go. We're also seeing a lot more women veterans now. And one other thing I'll mention that I didn't even think about, because I've been in the VA for 35 years, even though I'm trained as a pediatric geneticist, you have to be over 18 and healthy at the time you enrolled in the service to be able to get into the VA. So we don't see pediatric cases. Now, this is not your grandfather's VA. We see a lot of women vets. And so we're doing perinatal care now. And we're doing, I didn't think that I'd get back to doing prenatal counseling. And hey, and it's actually fun. But we're not doing nearly as much of that as you might think. So this is data, and I tried to find data on how the VA is doing with access to disparities, and this is a paper that I was a co-author on, and I sort of forgot it. And what it did was it was looking right as I started rolling out the genetic service in 2011, and we decided to just say, are people compliant with NCCN guidelines for BRCA1 testing? That was something, we couldn't look at family history, but we looked at the other things, age, multiple primaries, et cetera. And just did a poll and found, I don't know, it was a little under 500 people in a poll from two years, and then said, did they get testing? And it was about a quarter of them. And I thought that was pretty disappointing. I'm still disappointed with it. But then, and we looked on a univariate analysis, we saw disparities by age. It wasn't good enough, but if you were 25 when you got breast cancer, you were more likely to be tested than if you were 45. And there was a big racial disparity. But then when we sorted by medical center and did a multivariate analysis, the race fell out. And it turns out that whites and blacks in parts of the country, so that income distribution sort of matches it, were less likely to be referred. So it depended on the medical center. So this was basically the same time as at the bottom there. It was at the start of our national rollout. And so we know that the places that did have a cancer center were more likely to provide testing. And so there's sort of the Hayflick effect, from an experimental point of view. If your center has access to it and your colleagues sitting in clinic are saying, oh, well, you should do a genetic referral. How do I do that? Here's how you do that. Very quickly it gets adopted into that VA's culture. So that's what we're working. So the Genomic Medicine Service, dear to my heart, I was hired in 2010 to be the national director, and what I didn't know was there was nothing to direct. It was, it sounds really good. and so it's been a building process. And since then, now we serve 80 VAs. We set up MOUs and TSAs, and we started by giving telehealth to the medical centers and then to their CBOCs. Their community-based outpatient clinics, at 1,100 people. We've just started doing telehealth direct to home. And one of the things that the VA did was we published that we can do that across state lines regardless of licensure or anything else. We're declaring federal supremacy. We have our own guidelines, and everyone has bought that, including me. So I can show you, and then we also push the notes, just procedurally, we push the notes into the local patient record. And so from the provider's point of view, ordering these consults or receiving the consult, they don't know that we're just not in another floor of the hospital. Here's where we reach now. That's pretty good. Ironically, a lot of the heaviest users are from the academically affiliated programs that have active cancer centers because they knew and they were first in line. We have a backlog of 40 VAs that want our service. Our services, we do about a quarter e-consults. A lot of those come from lab services. We're sort of the final arbiter of is this test indicated? Because, a medicine resident walking through a neurology clinic will order $40,000 worth of tests in an adult onset neurological syndrome of unknown that they can't diagnose. And it might have taken a family history first, and it could have helped them. About 50% are video telehealth encounters, and then a lot of the phone encounters are by follow-up. We see referrals from every place in the VA, including the emergency room. And so where we're active, it's actually pretty cool. A lot of ours are from the women's health because of the breast cancer. Most are from primary care, over a third. And then hematology, oncology. Other big services are GI, neurology, and cardiology. And so so we see, again, the adult onset genetic conditions. I'd also say, I'm not talking about somatic cell genetics. I hope everybody here has an idea what that means, even though our patients don't. We've also, in parallel, have a precision oncology program. It's now rolled out over 60 VAs, and we're pushing to make both of these programs nationwide. We do interact with each other, and so that they can feed us referrals. I think one thing I have to touch on is the barriers to data. We've provided care with a VUS and BRCA1 to a Filipino woman. We don't have any data. And so there are a couple of things that I'll just mention. The Million Veteran Program is dear to my heart. It's recruiting. You can see the ages on the left, but on the upper right by race, we have about 18% Black, and then a splitting of everything else. One other very large program is the PRIME. It's a study. It's an empiric trial of pharmacogenomics to see with the first hard endpoint of improvement in depression. And there's a 6-month delay in unmasking results. And this is consented. We're also studying the providers. But again, we're on the upper left there, you can see that we're recruiting. Only 2/3 are Caucasian and 20% are African American. So this is a 20-site, multi-site trial. And so I really hope that we can get more data, and that this is a benevolent, not profiling, but just statistical analysis to get the data to appropriately treat the patients that we need to serve. So I think the best thing that we can do to address disparities in care is to provide the service to every place we do. Usually when we go in, we start by giving in-services and grand rounds. So we talk to certainly the women's clinic, but also to the oncology services, primary care, and talk about the kinds of things we do. Pathology often refers to us as well. And again, they can just see us. I think we need to continue research, and then development of educational materials. I really didn't get into, but the light is blinking. And but everything that we develop is public domain. So thank you.